Welcome to the Illinois Primary Healthcare Association's Health Talks podcast. On this podcast, we highlight incredible individuals who advance community healthcare, advocacy, and public health while striving to improve patient care.
I'm your host, Stacy Agosto, and I'm here today with Dr. Kathleen McDonough and Dr. Buswell from PCC Wellness in Illinois. They are both board certified in family and addiction medicine and are sharing a wealth of knowledge on treating substance use disorders, chronic illness, and have done a lot for our state and our communities around treatment and training. I'm very, very excited to have these two with us today. Dr. Buswell and Dr. McDonough, thank you so much for joining.
Thank you so much for having us. Excited to be here.
Yes, thanks, Stacy.
Absolutely, absolutely. If you are following the great trainings and offerings that we have with IPHCA, we offer a number of on-demand and live webinars and trainings for both providers and integrated care team members. Dr. McDonough and Dr. Buswell just finished an awesome training on buprenorphine initiating treatment and helping care teams treat patients with substance use disorders. So we're looking forward to a great conversation today. Between the two of them, they have extensive knowledge and experience treating patients, obviously. So I'm really excited to talk with you today. And I'd love to just start with, for the both of you, maybe we start with you, Dr. Buswell. How did you get interested in this work?
So I got interested in treating people with substance use disorders during my medical school training. I went to the University of Rochester in upstate New York, and sort of by chance just got involved with this project with a local syringe service program or syringe exchange that was doing harm reduction work in the community. And I was helping with a project that was working on assessing people's reproductive health needs, people who are coming to the syringe exchange. And so I spent a lot of time doing surveys and doing community-oriented research there. And just, I think, started to get a sense of a lot of the health disparities that exist in this population, and talking with people and understanding all of the many reasons people are scared and about going to the hospital or about seeking healthcare, and a lot of the stigma that patients face. And so that was kind of my entry to learning about healthcare for people with substance use, and then went on to do family medicine residency, an addiction medicine fellowship to get more training, and just have always found these kind of encounters and working with this patient population really rewarding.
Awesome. Thank you for that. So you think it was probably, it sounds like, connecting with people and hearing their stories that got you interested.
Yeah, definitely. And then I think that part of what I love about medicine and about why I chose family medicine is really getting to build a partnership with a patient and see them over time. And I feel like the substance use care reflects that partnership model really well, because your goal is to understand, what is somebody's goal for their health, and you're meeting them wherever they're at to work on that goal together. And I feel like that kind of parallel and that partnership relationship was what I really loved about medicine. And I feel like substance use care is one of the places we can do that really well.
Yeah, that was an awesome answer, Dr. Buswell. For me, it was twofold. So I graduated residency in 2009 and have always worked on the west side of Chicago in the Austin community. And in 2011, a few of us family doctors started prescribing buprenorphine. It came out of just an identified need from the patients themselves. So the patients were actually coming to us asking for help for treatment of their substance use disorder, just because I think back then it, wasn't as mainstream and it was harder to find treatment. And I think, being a family doctor, right, you're taking care of all their chronic illnesses, and it was just a privilege to be able to address this chronic disease as well, something that they trusted us, start treating. That was first part of it. And the second part was just personal experience. I have a sibling in recovery. And so I think just going through that with kind of seeing my family, that side of it just changed my perspective on substance use in general, and just, it became more personal to me.
Yeah. Yeah, I hear that. And I think it sounds like both of you saw a need or saw people that were looking for help with something and you leaned into that. And I can relate to the personal connection and the family connection as well. For me, I in therapy behavioral health worked on an integrated team in a health center for many years and also saw patients with substance use disorders. Getting into the work was a little more difficult for me. I felt like, I was very hesitant to go into working with substance use disorders. And looking back on that, I think that some of that was obviously stigma, but also a little bit of fear, feeling intimidated. The three of us probably have spent a lot of time training and working on bringing this information to providers across the state to get them more comfortable in prescribing and treating patients. In your experience, where do you think providers get stuck when thinking about treating substance use disorders? Maybe we start with you, Dr. McDonough.
I think there's a couple of things, right? Especially, like, I can speak as a family doctor.
Mm-hmm.
We see patients in a setting where the appointments are every 15 minutes, right?
Right.
Oftentimes our patients are medically underserved with a lot of chronic diseases that might be poorly controlled. And so I think when you're thinking about maybe adding one more thing to that visit, it feels very overwhelming. So I think that can be like a big barrier in terms of, kind of wrapping your head around treating patients with substance use disorders, and where are you going to fit this in, and how can you possibly do this effectively?
Right. And it's just the sheer time constraint. Is
Yeah.
yeah, right. Trying to address medically complex, many different needs and wanting to get it right. And then feeling like if you don't have the training at that point, maybe feels difficult to start.
Yes, absolutely.
Dr. Buswell, any thoughts on that?
Yeah, I very much relate to the time constraint. And in primary care and even in addiction medicine, it's, where we also address people's primary care needs. I think it can feel very overwhelming. I think the other point that I still find myself sometimes feeling stuck or feeling overwhelmed by is oftentimes with substance use treatment, the plan you're going to come up with does not feel like an ideal plan, or it feels like there are a lot of unknowns or there are a lot of variables, and you're starting a medication on somebody who's currently unhoused and who has a lot of other stressors going on, and ideally you would love to be able to address those needs or feel like they're in a more stable place when you're starting this new medicine. And so I think sometimes it can feel like the plan that you come up with doesn't, it just feels like there's a good chance that it's going to fall through, or that, it's not going to work. And I think as a provider, for me at least, sometimes that feels bad or feels like unsatisfying. You feel like you wish you could have done more, or wish you could have had a more kind of foolproof plan that you come up with together at the visit. But I think what I sometimes have to remind myself is that, the goal is engaging people in care, and that is the whole reason why we make a plan for follow-up. And hopefully, like our clinic, we're lucky to have a big team with peer support and nursing and care coordinators and just this amazing wraparound team. But I think that that kind of uncertainty about like, oh, this feels like it's risky plan, is this going to work? But I sometimes have to take a step back and just remind myself, like, we're going to try this, the patient is here today, we're working on this, we're going to come up with a plan together, and if that plan doesn't work, you can always make a new plan when you see them next. And just kind of not being afraid to try something because the person's there and wanting to get help.
Totally. And I was going to say, Mary, because I think that just rings so true. I was thinking about, like, kind of where things were when I started in 2011 to where we are today. And I remember at the beginning of prescribing, and as a prescriber, I was like, wait, what do you mean they're still using? And I'm prescribing this medication. Like, I just couldn't wrap my head around that, right? And then you just realize that it's so much more complicated than that, right? And at the time, I was so grateful for my social work counterpart who was like, well, this is harm reduction. And, and I think that, as you mentioned, like keeping patients engaged in care, right, is the most important thing. And the plan that you make on day one may look very, very different than the plan, that's in front of us. But we work on it together with that patient. That's that partnership. And, the care team is so important, as you mentioned. So.
Yeah, I think that's such an awesome point. And we've talked a lot about the time constraints in a primary care setting and having 15 minutes and how challenging that is for both patients and providers. But I love, Dr. Buswell, that you touched on this kind of like needing to be comfortable with things not being ideal or necessarily in place, and probably the patients feeling that as well. Hoping
Mhm.
that other, things would be a little more stable, certain patients, but we've got to start somewhere. And I think folks in our field, they're very conscientious, wanting to do things correctly, wanting to do things by the book sometimes, and getting a little comfortable with like, oh, we've just got to roll with what we have in front of us is a different way of working.
Mhm. And I think that, like, once you start doing it and once you see, treatment working, you do like, you build that comfort and then realize that, yeah, these are life-saving medications. But when you're treating somebody's substance use disorder, you have the opportunity to, make a big impact in that person's life, but also all the, lives around them. And so I think the potential reward or the potential benefit of starting somebody on treatment, even when it feels like it's this kind of unstable or suboptimal scenario, the when you start to see patients coming back and telling you how things went and start to see things going well for people, it makes me at least feel a little bit more comfortable of, I've had these scenarios where I thought, this, wasn't going to work, and then somebody, comes back and they're doing great, and that's really, really rewarding to see. And also I think shows that sometimes as, doctors, we don't know how to predict the future. We don't know who's gonna, how things are gonna work out for someone. So sometimes you just have to try something and then tell people to keep coming back even if it's not working, and you'll
Right.
try something different.
Right. Right. And I think, you both touched on working with interdisciplinary team and folks with different professional backgrounds and lived experience. And I know at PCC, that's a big part of the care. And when we've talked about it, trained on it, and read about integrated care, there is evidence to support it helps protect against provider burnout. It's something that maybe is a protective factor for everyone on the team regarding burnout. Has that been true for your practice? Is that how one piece of the way that you think about it? Maybe Dr. McDonough, we start with you.
Absolutely. Yeah. I don't think that the work that we're doing could be done as well without all the members of our care team. So we're fortunate to have nurses and peers and peer doulas and social workers. And it's like that saying, like many hands make light work, right? It's just, and everyone brings a different perspective to the treatment plan. And I really, really value that. And so I think it's just important to have those different perspectives, and it makes our jobs really enjoyable, I would say. And also I do agree that it, prevents burnout, having that additional support for our patients, because we know that oftentimes these patients do have a lot of needs. And so it's just really beneficial to have all those additional hands.
Right. And, some pieces of burnout can be, well, you all tell me if you agree or not, but some pieces of burnout can be, I need someone else to bounce this idea off of. I need somebody to consult with. I need help with referrals, or maybe someone else who has a little bit more time or different time than I have to get a deeper perspective on this patient. All of those things that other care team members can help with in terms of protecting against burnout and just the short amount of time that you all have to see patients. Dr. Buswell, any thoughts that you have on that?
Yeah, I think in addition to interdisciplinary team, having colleagues who are also working in this field and kind of developing that community of support is very helpful. Like I recently finished my addiction medicine fellowship, and so talking with my co-fellow or other, friends from residency or training who did addiction medicine or who are practicing addiction medicine is a very helpful way to run kind of general questions by people or discuss some of the challenges. So I think that also helps with managing and mitigating burnout.
That's great. As you all both know, and I think you've been involved in some of these, we do at IPHCA a lot of trainings and discussion on integrated care, as we've been talking about, meaning, having a full team, team-based care kind of wrapped around the patient and supporting the medical provider as well. One thing that I hear from behavioral health folks, peers, other maybe community health workers, people that are not medical providers, they'll say that sometimes approaching medical providers can be very intimidating. These are very smart, very busy folks. And, in the provider room, it's busy. There's a lot going on. You don't want to interrupt anybody. You don't want to step on anyone's toes. So if you're thinking about kind of the ways that you interact with different teammates, what are some of your favorite ways that you've seen teammates advocate for patients, teammates kind of catch your attention? What are some of the ways that works for you?
I think one of the things that I think has been beneficial for our team is doing a team huddle before clinic sessions.
Yeah.
And, you have your peer there, you have your social worker there, you have your nurse there, and you truly are a team in that moment. And everyone is contributing to that, the discussion on the patient's care. And I think that helps break down, kind of barriers in terms of that fear of maybe approaching a provider, things like that, right? That is the time where you are just letting those team members know how valuable their input is, right? And I truly, people may have heard me say this before. I'm always like, I'm just a prescriber. Like what the social worker does, what the peer does, what the nurse, that is the hard work and truly remarkable. And I just think it's invaluable. So I think a huddle is a great way to kind of make sure that every voice is heard and everyone feels like they're contributing equally to the patient care.
I would say I can relate to the feeling of being nervous to, interrupt somebody or lend a different opinion. I think that really resonates having just gone through, medical training myself and recently finished residency. Sometimes can be, nerve-wracking to interrupt or, what feels sometimes like questioning someone else's approach. As now being on the other side of training, I so welcome that when people lend a different opinion. I think it's setting the intention when you talk to somebody and just say, hey, I'm really, worried about this patient. Do you have a few minutes to talk about their care or something like that, just maybe reminds the person that you're aligned and that you're, both kind of have that shared goal. And when it's approached like that, I feel like I at least am so grateful to have people who are, looking at things through a different angle or different lens.
Yeah, I think you both are coming at it from a place of humility and respect for other disciplines and experience. And I think if all of us on a care team are coming from that place, it tends to go well. Everybody's busy, but just, trying to approach it with respect and all in the name of the patient's care. But just to push the question just a little bit, Dr. McDonough, you in the training that we did last week, you told a cool story about someone who had, it was a peer support worker, a teammate who was advocating for a patient, and I believe was in the OUD program, who had just given birth. And the peer support worker, I would say, maybe pushed conversation around a decision and wanted to talk to you about that, could have come across as challenging or challenging a decision the medical team had made. And I think being a non-medical provider, I think that's a really difficult call for us to kind of say okay, the patient is telling me this, maybe I have a little different information or more information than the provider, but how do I say this in a way that's not going to, sever my relationship with the provider? So what do you think worked for you in that conversation that you were able to hear it and not get defensive or not see that person as challenging? What do you think worked?
Yeah, I mean that was a really powerful interaction for me and for the patient, and I think for the peer. The peer pulled me aside, so it was just the two of us, and I think that that maybe is important too. You don't feel like you're being kind of singled out in a larger audience or
Yeah.
something like that.
Yeah.
And just a very respectful conversation. And she just offered her perspective as a peer, as someone who has walked in the shoes similar to the patient. And I think that is just so invaluable, right? Sometimes as providers, I know we can be rigid, right? Our
Hmm.
protocol was postpartum, we switch them to buprenorphine naloxone. They may have been on the mono product, and she just came up to me and she's like, I've been a mom. I'm a mom in recovery. Like, why rock the boat? Like, the postpartum period is so hard as is. Like, why are we going to make this change? And, I am also a mom, and I also recognize how hard that postpartum period, is without having to struggle with substance use. And so I just think, again, just kind of pulling me to the side. It was a very mutually respectful conversation. She just brought up her experience as a mom in recovery, related that to the patient. And then also, there's aspects of it that I could also relate to as well. And so I think that for me, there was no, ego or anything. I was
Hmm.
just, you're totally right. Like, thank you so much for bringing, because I just wasn't, I was thinking about our protocols, right?
Yes.
And not necessarily like the patient in front of me. And so just that additional perspective is really, really valuable.
Yeah, I think that's such a great story and such a great example because both people are coming to the patient care with different, like you said, different training, different perspectives. Your mind is on the protocols as it should be. And you need the information from the peer, to kind of bring in the art side of it, and you're bringing the science side of it, and
Totally.
I think that's just awesome and like a great example of maybe how to approach. I like that you said maybe we pull you aside and say let's talk just the two of us, so you're not putting anybody on the spot, and just talk about it. So
Yeah.
that just says a lot about your ability to work as a team. That's the whole point of it. This has been such a wonderful conversation. I wonder if you both could share what is your favorite part of doing this work when you think about substance use care, family medicine.
I think being able to work with patients over longer period of time, sometimes inside the hospital, sometimes in the clinic, and get to work together to navigate various challenges is very rewarding. And I also think something I love about both primary care, but certainly substance use treatment and addiction medicine, is being able to, like, hopefully, the goal is to provide an experience in the medical system that can be positive, because I think
Hmm.
patients have so often had these really, negative experiences trying to get their health care and address their needs, and to be able to be a part of a little sector of the healthcare system that can really work with this patient population and help meet them and meet their goals, and a welcoming place. I feel like that is such a rewarding thing to get to be a part of.
Yeah, absolutely.
Yeah, for me, and I've said this before, I think as primary care providers, we all struggle with burnout, and kind of finding joy in addiction medicine has really reinvigorated like my love for medicine in general. Like, addiction medicine is definitely like the high point of my day and of my career right now. I just love doing that work. And I think it's, as Dr. Buswell said, like kind of seeing patients over time and working on a problem with them over time, and just kind of celebrating even those very, very small wins with the patients is just really rewarding. It can be, I haven't used in 3 days, or I've been taking my medication as prescribed, to something more like now they're working at PCC, as a peer, or just kind of seeing all of those things. And it's not all rainbows and unicorns, certainly, but just, being able to celebrate those small wins just brings me personally a lot of joy in my job day to day, and has helped me continue on as a primary care provider too.
Yeah, that's wonderful. I think sounds like both of you enjoy walking alongside the patient and seeing their journey and being a bright spot in the healthcare system when many of these folks maybe have been stigmatized or brushed aside or just have had difficulty accessing care. So that's wonderful to hear, and we are very lucky to have you in our community health system here. Thank you both so much for joining us on the podcast today and sharing your knowledge. We really, really appreciate it. If you are listening today, you can access training from Dr. Buswell and Dr. McDonough on our on-demand library on our IPHCA website. And please like and subscribe and tune in to future IPHCA Health Talks podcast. Thank you so much, and we'll see you next time.